And now we will start Astra Symposium. These are my disclosures. And I will be talking about another treatment option in the metastatic castrate-resistant prostate cancer. And I think this will be either the PARP inhibitor alone or in combination with novel hormonal treatment. And today we have heard a talk by Dr. Yahya Omar on the role of lutetium. So after we have listened to the triplet therapy in first-time metastatic hormone sensitive, I think what is left right now will be PARP inhibitors alone or in combination, or lutetium PSMA as a treatment option in the metastatic castrate-resistant prostate cancer landscape. As we all know, metastatic prostate cancer is biologically heterogeneous, with around 90% patients have genomically apparent pathways. As regarding DNA repair pathway, 23% of mutations were identified in the DNA repair pathway. And as regarding genetic testing, it is now standard of care in prostate cancer, and we have to offer testing to all patients with metastatic prostate cancer. Mutation may be either germline or somatic. Somatic DNA testing results may change over time due to the genetic instability of tumor DNA. And as regarding the percentage, 23% of metastatic castrate-resistant prostate cancer have DNA repair alteration. In a paper which was published before in 692 men, 11.8% with metastatic prostate cancer had germline DNA repair defects. If we look at the enrichment analysis of the DNA repair defects in metastatic castrate-resistant prostate cancer between the primary and the metastatic, in the primary, DNA repair defects were 11%, while in the metastatic, it was 21%. So the NCCN guidelines recommendation for germline mutation testing in patients with prostate cancer, those with positive family history of cancer, breast, ovarian, pancreatic, prostate, colon, endometrial, regardless of stage of the disease, those with known DDR mutation in the family, BRCA2 or MSH6, those with personal history of prostate cancer with the following features: high-risk localized prostate cancer, node positive prostate cancer, metastatic prostate cancer, and consider in men with ductal or intraductal histology. What are the tests available for genomic and tumor DNA mutations? Tumor tissue biopsy, either from the primary or metastatic, or liquid biopsy, cell-free DNA, circulating tumor DNA, and circulating tumor cells. PARP inhibition leads to increase in double-strand breaks and prevents recruitment of DNA repair enzymes to single-strand DNA breaks, or traps PARP on the DNA, which leads to failure of single-strand DNA repair and accumulation of single-strand DNA breaks, and replication fork is arrested at damage and produces double-strand DNA breaks. As we all know, in homologous recombinant repair deficient cancer cells treated with a PARP inhibitor, olaparib, for example, double-strand breaks can only be repaired using error-prone pathway, which at the end leads to cell death. The story of synthetic lethality hypothesis is very simple. If you have a normal cell with normal PARP function and BRCA function and non-BRCA mutation carrier, DNA damage, and adding a PARP inhibitor, the repair pathway is competent and which leads at the end to survival. While if you have a normal cell with a BRCA mutation carrier but one allele is lost, adding a PARP inhibitor again can be repaired through the function of BRCA. While if you have in cancer cells BRCA mutation and both alleles are lost and you don't have a PARP function and you don't have a BRCA function, this at the end leads to synthetic lethality and cell death. So why are we need to improve the standard of care for men with metastatic castrate-resistant prostate cancer? Because metastatic prostate cancer, around 40% of patients with prostate cancer will develop metastasis. Advanced prostate cancer is incurable and reliably progress is often fatal, and 5-year survival for men with metastatic disease is around 30%. And the opportunity to improve standard of care for metastatic castrate-resistant prostate cancer, despite responses to initial ADT, the majority of advanced prostate cancer will become castrate-resistant. Here is the landscape of systemic treatments for metastatic castrate-resistant prostate cancer. We have novel hormonal treatments, ANSA and abiraterone, either in the trials before docetaxel or after docetaxel. We have docetaxel as an option, and we have cabazitaxel as an option. We have radium-223 for selected patients with bone-only disease, and we have the approval of olaparib in 2020 according to the PROFOUND study for BRCA1 and BRCA2 and ATM mutated patients with the highest overall survival, 19.1 months, and we have recently the approval of lutetium PSMA according to the VISION and therapy trial. But in real life, what we have learned that all the novel hormonal treatments are used in first-line metastatic hormone sensitive, and recently we have heard about the ARASENS and the PEACE trial in which we use the novel hormonal treatments plus ADT plus chemotherapy. So what is left for metastatic castrate-resistant prostate cancer? If we are asking about sequencing, it's a very important question. We are using everything in first line. So what is left in the castrate-resistant is only right now. For example, if we give the triplet therapy, what is left is only PARP inhibitors, either alone or in combination, or the lutetium PSMA, because the other agents like Siblucil is not available in Egypt, and radium-223 is for selected type of patients. We have ongoing trials combining PARP inhibitors and IO, but still what we have right now is PARP inhibitors and lutetium in metastatic castrate-resistant prostate cancer. If we offer ADT plus a novel hormonal treatment, or we offer everything in the metastatic hormone-sensitive setting. So, in the Advanced Prostate Cancer Consensus Conference last year, there was a very important vote as regarding sequencing of treatment. The question was, in the majority of patients with a pathogenic BRCA1 and 2 alteration, germline or somatic, who have received an ADT and an AR pathway inhibitor, what is your next systemic treatment recommendation? And around 75% voted for a PARP inhibitor. While if the same patient have received novel hormonal treatment, ADT, and docetaxel, what is your next treatment recommendation? A more vote for PARP inhibitor with 82% versus an alternative AR pathway inhibitor or alternative AR pathway plus a PARP inhibitor or cabazitaxel or radium or lutetium. So, as regarding metastatic castrate-resistant prostate cancer, either if the patient have received a novel hormonal treatment plus ADT in the first metastatic hormone-sensitive line, or novel hormone treatment and docetaxel, PARP inhibitor was the major vote in as regarding sequencing treatment from the last consensus conference last year. So what was the rationale for PROFOUND? It came from study 42 and the TOPARP trial. Study 42 demonstrated tumor responses in patients with germline BRCA mutation advanced prostate cancer, while the TOPARP had TOPARP A and B phase. TOPARP A was for all comers, metastatic castrate-resistant prostate cancer, and retrospective biomarker analysis was done after that, and it has shown that the activity in patients with DNA damage repair defects, including homologous recombinant repair, wild-type metastatic castrate-resistant prostate cancer, while TOPARP B validated the results of the TOPARP A study in biomarker selected metastatic castrate-resistant prostate cancer. And if we look at the results from the TOPARP A, olaparib improved outcomes in patients with metastatic castrate-resistant prostate cancer with homologous recombinant repair gene defects versus those without these defects, with median radiographic progression-free survival 9.8 versus 2.7 in the biomarker negative subgroup. And if we look at the overall response rate in the biomarker negative subgroup, it was 12.5%, while in the biomarker positive, it was 87.5%. And in the TOPARP B, in which the study was prospectively evaluating the homologous recombinant repair genes defect, we have seen that the confirmed response for group 1, which was BRCA1 and 2, the response was 83.3%, group 2 ATM was 36.8%, group 3 CDK12 was 25%, and group 4 for PAD2 it was 57.1%. So, the first part take-home message is prostate cancer is a heterogeneous disease. Around a quarter of patients have an underlying DNA damage repair aberration, and outcomes for patients with metastatic CRPC still remain poor, and olaparib target homologous recombinant repair deficient cancer cells according to the PARP and the study 42, and PARP inhibitors are recognized as novel therapies to treat treatment with deficiencies in homologous recombinant repair pathway. Then came the PROfound study, in which patients are randomized after progression on a novel hormonal treatment, and the progression of taxanes was not mandatory in this study, and this is a difference between the approval of olaparib and rucaparib, in which it has mandated to receive a novel hormonal treatment and prior taxanes. And here it has two cohorts, cohort A, BRCA1 and BRCA2 and ATM, and cohort B, the other 12 homologous recombinant repair genes. And patients will receive in a randomization 2:1 olaparib 300 mg twice daily versus physician choice in cohort A, and the same for cohort B, and crossover was allowed in this trial after progression to receive olaparib. The endpoints in the PROfound have been analyzed in a hierarchical procedure, and this means that if the primary endpoint demonstrated statistical significance, the key secondary endpoints were tested sequentially, and this multiple testing procedures was used to control for type 1 error rate. Here, cohort A, as we have said before, BRCA1 and BRCA2 and ATM, and cohort B included other 12 homologous recombinant repair gene panel, including Fanconi anemia, PALM2, CDK12, and RAD homologous recombinant repair genes. And 15 genes were tested, were a subset of the genes covered in the Foundation 1 comprehensive cancer panel of cancer-related genes, and cohort A, as I said before, was BRCA1 and BRCA2 and ATM, and cohort B was the other 12 genes. Around 30% of patients were identified with a qualifying homologous recombinant repair mutation in the screen population in line with current literature, and a similar proportion of patients were identified with homologous recombinant repair irrespective of whether the tissue was derived from the primary or the metastatic site. And what was seen that BRCA2 and ATM and CDK12 was the most prevalent homologous recombinant repair mutation identified. So, PROfound was the largest study, biomarker selected study. It was included 4,000 patients and were recruited on a two-stage screening process. 15 homologous recombinant repair genes were selected to cohort A, BRCA1 and BRCA2 and ATM, and cohort B, the other 12 genes. What about tissue testing in the PROfound study? The objective was to report additional findings of prospective central tumor testing of samples from the PROfound study, and here the majority of samples were assessed in the study were found from archival core biopsies derived from the primary tumor. And here we want to show what is best, the archival, what is the origin of the specimen, the collection method, and the organ from which the biopsy was taken, and the sample age. And what we have seen that the success rate were higher with newly collected versus archival samples, and samples derived from the metastatic sites versus primary tumor. So the most common reason for the test failure were different depending on the age of the sample. Archival samples were more likely to fail at the stage of DNA extraction, while newly collected samples were most likely to fail at the pathological review. So, first message is newly collected samples were better than archival, but in the PROfound study we had archival tissue with around 10 years in the study. And also primary versus metastatic, and we have seen that the results of the metastatic was more confirmed than the primary. Also, core needle biopsy was the most common collection method, but the lowest test success rate was for core needle biopsy, and the higher testing success rate was from radical prostatectomy and QRP. Also, the majority of samples were collected from prostate tissue and over a broad time, which was from less than 1 year to more than 10 years, and tested success rate for prostate cancer was relatively low versus other organs, which could be due to a high proportion of prostate samples were derived from archival core needle biopsies, with varying amounts of tissue remaining in the block due to utilization for initial diagnostic workup, and a variable nuclear density of the tissue dependent on the part of the prostate sample and the amount of tumor in the core. Testing was the lowest in bone, and we all know, due to degradation of nucleic acid from decalcification, and lymph node samples had the highest testing success, and also higher testing success was seen in more recently collected samples versus older samples, which may be due to nucleic acid degradation of older sample impacted by storage conclusion. So, from the profound as regarding tissue testing, we have seen corneal biopsy yield lower success rate than samples from the prostatectomies and was the most common collection method in the study. Small residual tissue sample size barely reaching the minimum tissue volume input may be a limiting factor for successful test outcome. As regarding age, older samples were associated with a lower success rate when the majority of samples were from archival diagnostic biopsy or resection tissue. Successful testing was possible with post-archival around 56.9% and recently collected samples 63.9%. Most samples were from primary tumors, however, success rate was higher for metastatic samples than primary samples, which may be due to the higher cellularity and tumor content that primary samples were archived. A profound common reason for test failure was that samples didn't meet the pathology requirements or had insufficient yields of DNA after extraction, and this highlights the critical importance of selecting high-quality samples and optimization of tissue collection to improve NGS testing success rate. And I know Astra have made several workshops for the improvement of tissue testing and for taking the tissue biopsy. If we return back to the profound study, the baseline characteristics were generally well balanced between both arms. And if we look around, 1/3 of the patients were taxane naive, and 1/5 received 2 prior taxanes, and 1/5 received 2 prior novel hormonal treatment before randomization. Just over half patients had measurable disease at baseline, and the majority were performance scale 0 to 1, and there was a higher median baseline PSA in the physician choice arm. However, the range was balanced between both arms. As regarding the type of mutation, BRCA2 and ATM and CDK12 were the most prevalent genes of qualifying gene alteration in the randomized patient reported, and also a co-occurring alteration in more than one homologous recombinant repair gene was detected in 2.1% of screened patients with a qualifying gene alteration, and 7.2% of randomized patients most frequently associated with BRCA2, ATM, or CDK12. The profound met its primary endpoint. Olaparib significantly improved radiologic progression-free survival by blinded independent center review in patients with alteration cohort A BRCA1 2 ATM versus physician choice, with a progression-free survival of 7.4 versus 3.5, with a hazard ratio of 0.34, and the subgroup analysis showed benefit in favor of cohort A, BRCA1 and BRCA2 OATM versus physician choice of treatment. 1/3 of patients in the olaparib arm achieved an objective response and a 21-fold increase in the odds ratio of olaparib compared with the physician choice. And the PSA response and the circulating tumor cells provide another method of assessing response in patients and are parameters to consider, particularly in those patients that don't have measurable disease. And if we look at cohort A, reduction of PSA to more than 50% from the initial PSA response was 43.1% in the olaparib arm and 7.8% for physician choice of treatment, and CTC conversion was 29.9% in the cohort A versus 11.4% for the physician choice of treatment. And also, if we combine cohort A plus B, the median progression-free survival was 5.8 versus 3.5. And if we look at the median time to pain progression in cohort A, it was not reached, and for physician choice it was 9.9 with a hazard ratio of 0.44. And if we look at the overall survival, remember, if we compare all the trials in the metastatic castration-resistant prostate cancer, we see that a median overall survival of 19.1 months is the highest for treatment options in metastatic castration-resistant prostate cancer. And here we see that olaparib has reduced the risk of death in cohort A by 31% compared with physician choice treatment, despite substantial crossover. And here we see, if we do an adjustment for cohort A and remove the olaparib, because around 67% in cohort A of the patient had crossed over after progression to receive olaparib, the hazard ratio from 0.69 has become 0.42 after adjustment for crossover. Again, if you combine cohort A and B and look for the overall survival, before adjustment it was 7.3 versus 14 months with a hazard ratio of 0.79, and if we remove the olaparib, patients who have received olaparib after progression, the hazard ratio became 0.55. A very important question is what is the overall survival for the patients who didn't receive taxanes? It was the best. If we look at the patients who didn't receive prior taxanes, the hazard ratio was 0.3. But if the patient had received a prior taxane, the hazard ratio was 0.64. So the response is better for patients who have received a novel hormonal treatment and didn't receive taxanes and have homologous recombinant combination gene defect and have received olaparib. So overall survival forest plot shows benefit for cohort A, BRCA1 and BRCA2 or ATM versus the physician choice of treatment, and there was no significant difference in deaths due to adverse events in the overall population or crossover population. And if we look at the median time to first onset of the most common adverse events, they were all within the first 3 months and were typically resolved within the first 6 months of treatment. So, I have some take-home messages. Consider assessing homologous recombinant status early. Retrieve blocks. Consider rebiopsy. BRCA1 and 2 mutation rarely change status over time. PARP inhibitors are currently approved after progression to androgen receptor signaling inhibitors. Use a target next generation sequencing panel for BRCA1 and BRCA2 and other homologous recombinant genes if possible. And we have to test for mismatch repair and MSI. When possible, analyze a recent tissue sample, metastatic biopsy, and we have seen from the found that metastatic is better than the primary, and lymph node is better than others, and the worst is for bone. Sequencing of primary tissue is also possible, but consider sample age fixation. Liquid biopsy may help overcome difficulties of tissue analysis, but also has limitations. Germline testing only will miss about 50% of patients eligible for PARP inhibitors, and all patients with metastatic prostate cancer should be offered germline testing. Somatic tests are not validated for germline assessment, and 7% of alteration may be missed. Offer germline testing to patients at high risk of being mutation carriers despite negative tumor sequential results. Analyze potential germline origin of mutation in cancer-related gene which are found on the tumor. And from the messages from the PROfound, patients randomized to PROfound only needed to have progressed on a prior novel hormonal treatment, and this is the difference between the other PARP inhibitors. Prior taxane chemotherapy was permitted but was not mandated. Patients were certified by prior taxane therapy. Novel hormonal agents was chosen as a comparator based on FDA and EMA approval, clinical practice and available data. Since not all patients are suitable for chemotherapy, this choice allowed the PROfound comparator arm to have the broadest inclusion of patients. PROfound was conducted as an open-label study given the different treatment schedules and toxicity for the control arm, which meant that blinded study was not practical. Blinded independent center review analysis of the primary endpoint was used to minimize the investigator bias. Patients could cross over from physician choice of novel hormonal treatment because it is ethical to offer our patients who have progressed treatment available if they demonstrated radiographic progression and were fit to be considered for olaparib subsequent treatment. Due to the predicted high uptake of crossover to olaparib in the physician choice of the study, radiographic progression-free survival was chosen as the primary endpoint, with overall survival as the key secondary endpoint. And the final take-home message in patients with metastatic CRPC with disease progression on prior novel hormonal treatment, olaparib provided a statistically significant and clinically meaningful improvement in blind independent central review radiographic progression-free survival compared with physician choice of enza or abi plus prednisone in patients with alteration in BRCA1 and 2 or ATM, and in the overall population with alteration in any qualifying genes, which is cohort B. And olaparib also improved multiple other clinical and patient-reported endpoints, overall response rate, time to pain progression, and overall survival. And and there was also statistically significant improvement in the final overall survival for olaparib versus enza or abi in cohort A, with a median overall survival of 19 months versus 14. Despite crossover, and PROFOUND is the first positive biomarker selected phase 3 study evaluating a targeted therapy in men with metastatic castration-resistant prostate cancer, and olaparib is the only PARP inhibitor associated with statistically significant overall survival versus novel hormonal treatment. And here, if we will always ask about the option of sequential treatment. If our patients receive in the metastatic hormone-sensitive setting ADT alone, which is not a standard of care, right now the standard of care for metastatic hormone-sensitive prostate cancer is ADT plus something. ADT plus a novel hormonal agent, ADT plus docetaxel, ADT plus altogether novel hormonal agent plus docetaxel. But ADT alone is not an option. So if our patient has received ADT plus a novel hormonal agent, what is left is a PARP inhibitor and lutetium PSMA for third line, and docetaxel if the patient didn't receive docetaxel before, and if the patient, which is right now according to the PEACE and the AstraZeneca trial, have received all the first line, which is right now a problem, because what was left is only PARP inhibitors or lutetium Besma or cabazitaxel, and right now we have recent approvals of not only PARP inhibitor alone or PARP inhibitor plus novel hormonal agent, and according to the EAU, European Association of Urology guidelines, there is strong recommendation for the use of novel agents in metastatic castration-resistant prostate cancer after failure on docetaxel and one line of novel hormonal treatment, and the available options are PARP inhibitors in patients with homologous recombinant repair gene mutation, or lutetium PSMA for patients with one or more metastatic sites highly expressing PSMA exceeding the uptake in the liver. And right now I want to give you the good news, because we will have the approval right now in Egypt of the PROPEL study combining olaparib and abiraterone, and soon we will have several discussions and meetings on the approval of PROPEL in Egypt. And I will highlight only the Oncology Drug Advisory Committee meeting on PROPEL, which was in April 28, 2023, and they have discussed a supplemental new drug application for olaparib in combination with abiraterone for the treatment of patients with metastatic castration-resistant prostate cancer, and the committee voted 11-1 to limit the proposed new indication for olaparib in combination with abiraterone for patients with metastatic castration-resistant prostate cancer and a BRCA mutation. Then, in May 31, the USA FDA approved olaparib with abiraterone and prednisone for other patients with deleterious or suspected deleterious BRCA mutated metastatic castration-resistant prostate cancer, as determined by the FDA-approved companion diagnostic test. And then the EMA recommends the use of olaparib and abiraterone combination in all comers. Here is the latest NCCN guidelines for prostate cancer, and here if we look for patients who have no prior docetaxel and no prior novel hormonal treatment, olaparib and abiraterone for BRCA mutated patients according to the PROPEL study is category 1, and for patients who have received prior docetaxel but no prior novel hormonal treatment, again olaparib and abiraterone for BRCA mutation, while for patients who have prior novel hormonal therapy but no prior docetaxel, we have the option of olaparib for homologous recombinant repair mutation, category 1 according to the PROFOUND study, and for patients who had prior docetaxel and prior novel hormonal therapy, again olaparib is for homologous recombinant repair is the preferred category 1 option beside other treatment option. Thank you for your attention. Any questions? I think it's time for prayer. Thank you for your attention. Thank you.